what their role is in the treatment of colon cancer in our community. We'll start with Dr. Widener.
My name is Jeff Widener. I'm a radiation oncologist, so I treat cancer with radiation.
My name is Fernando Esinena. I am a colon and rectal surgeon, and my role in the treatment of colorectal cancer is cutting the cancer out.
My name is Saloni Tana, and I'm from the diagnostic clinic. I'm a medical oncologist, which means that I make recommendations on chemotherapy.
My name is Ankur Shah. I'm a gastroenterologist, and my role is in prevention, diagnosis of colon cancer, and I do screening colonoscopies.
All right, so as you can only imagine that a lot of the action tonight is going to be with Dr. Shep. So the gastroenterologist always gets a lot of the questions. So what we'll do, we'll go to about 6:45, and I've got a great view of the clock ahead of me. We'll go to about 6:45, and then we'll open it up to your questions. So if what we go over tonight doesn't answer your questions, then we'll just pass the mic around and, for 15 minutes answering your questions. And be thinking that when we do that, please don't ask real personal questions, because as you might know, that they don't know your past medical history or your current medical history, so it'll be really difficult for them to give you a personal recommendation. But general questions are absolutely just fine. So with that said, we'll get started. Oh, and remember, you have some tickets. We'll draw for that once we're done. All right, so make sure you hold on to your tickets. All right, Dr. Shep, we'll start with you. So this has been in the news a lot. You see it on TV and the little bouncing thing and all that. So what's the deal about the at-home screening test? What do you say about that?
So let me first start with what screening is. Screening is finding a disease when you have no symptoms. When it comes to colon cancer, there are two kinds of screening tests. You have screening for prevention of colon cancer and screening for early detection of colon cancer. The test that you're talking about, also called as stool DNA test or Cologuard, what it does is it detects abnormal DNA in the stool. Well, why abnormal DNA? As we know, cancer means there is abnormal multiplication of cells because of some abnormality in the DNA. So if there is a cancer in the colon, the theory is that some of that DNA will be shed in the stools, and the stool kit will pick it up. So that stool test is really for early detection of colon cancer, not necessarily for prevention of colon cancer. It works about 90 to 95% in detecting colorectal cancer. So it is a reasonably good test. It is better than nothing.
So yeah, I'm going to follow up with that, because I think I've heard it on the commercials myself. So if I've had a polyp, and if I've had a polyp removed, would this be a test you would recommend for me?
No. So that is really for a pure screening purposes. If somebody has a personal history of colon polyp, personal history of colon cancer, family history of any colorectal cancer, or any diseases that put them at higher risk than average, you do not want this test. In that case, you want to go for gold standard. Actually, I say you should always go for gold standard, which is a screening colonoscopy.
It stole one of my questions, but I will come back to that. Thank you so much, Dr. Seth. Dr. Tana. So Dr. Tana is an oncologist dealing with the treatment of colon cancer once it's diagnosed. So Dr. Tana, as a nurse involved in the treatment of cancer patients a lot, I hear about, we hear a lot about personalized medicine or targeted medicine. Are there drugs out there that you can that are more targeted to different types of cancer?
That's an excellent question. So traditionally, our chemotherapy has been kind of drugs that simply interfere with DNA synthesis. We're trying to affect rapidly dividing cells, and that's why we have a lot of side effects. But as time has gone on, we've learned a lot more about colon cancer and other types of cancer, and specifically looking at their biology and what different receptors these tumor cells may express. So we're starting to find out that there are different ways of treating cancer. There are tests that we can now do on a tumor specimen. So after a patient has been diagnosed, had a biopsy, once we have tissue, we can actually send that tissue to different labs, where we can look at the molecular level to see what is this person's tumor expressing or not expressing. and that helps us guide chemotherapy options. So this is still an evolving field, but we're learning more and more about treatments that work for each patient. And so yes, there is a role for personalized medicine. Thankfully, it's tests that can be run on specimens that have already been retrieved, and that's the direction we're moving in.
Great. I know we've seen all the years I've been in oncology, we've seen lots of those medicines develop for other cancers, and it's really nice to see that there's some out there for colon cancer. Dr. Asiana, when I'm a nurse on the floor, sometimes a patient has maybe gotten a diagnosis of colon cancer, and the first thing they worry about is if they have to have surgery. Does everyone that has colon surgery end up with a colostomy?
So that's a very good question again, and that's one of the myths, right, that we want to debunk tonight. Really, not everybody is going to end up having a colostomy after we remove colon cancer. As a matter of fact, it's not very common to do colostomies when we remove colon cancer. In certain situations, when we're talking about rectal cancer, which is a little bit, we put it together as colorectal cancer, but they behave a little bit different. They're located in a different area of your large intestine. So those cancers that are very, very low in your rectum, close to your anal opening, those can be a little bit more challenging. And those kind of situations, we present those cases with our specialists in tumor conferences and all, to see how we can do to save somebody from having a colostomy. And so even in those rectal cancer cases, we try to avoid. Not everybody gets a colostomy. Those ones who are going to get it are those ones that have a rectal cancer that is very low, close to your muscles that control your bowel movements, or somebody that already has a little bit of problems holding bowel movements even before the operation.
Thank you very much. I think that's again, as a nurse, I've heard patients worry about that, that having a colostomy, because that's something obviously none of us would ever vote for, right? So, Dr. Widener, you're involved in the treatment of colon cancer with radiation treatments. Can you tell us a little bit about the role of radiation? Are there any specific types of treatment that are different than other cancer treatments, or what's like the typical course? So if someone's getting radiation, what kind of typically how long do they have to go, and what's kind of that?
Typically for colon and rectal cancer, usually we don't treat any colon cancers with radiation. It's mostly rectal cancers, and we either treat them before surgery or after surgery. Usually it's about 5.5 weeks of treatment, Monday through Friday, 5 days a week. It only takes about 20 minutes a day to get your treatment, so it doesn't take very much time out of your day, even though it does take place over several weeks. So that's the typical course. They are experimenting with possibly doing 5 treatments before surgery, and that's something that's pretty popular in Europe. I don't think it's as accepted in the United States yet.
So you would do that to make it easier for Dr. Asiana to operate or to shrink the tumor? Is that the role of radiation before a surgical procedure?
That's one role. That's one role. If we think the tumor is advanced enough to need radiation after surgery, if we give the radiation before surgery, usually there's less side effects, and it can make surgery easier and improve the chances of not having to have a colostomy.
Okay. All right. That's very interesting. Thank you so much. Dr. Asiana, we're going to go back this way. You said I just answered a question, and I'm going to do it again. So tell me, you say you have a patient that presents to your office and you suspect possibly they might have colon cancer. What are some of the symptoms that you might see in a patient that has colon cancer presenting to your office?
Sure. So some of the colon cancers that we find are asymptomatic. So if you don't have any symptoms, you go to Dr. Shed's office and he does a colonoscopy and he finds the cancer. In other situations, you can have symptoms, meaning you can feel things. You can see changes in your weight. You can see changes in your bowel movements. They look a little bit thinner. They look a little bit darker. They look red. You might have some rectal pain. You might have abdominal pain. You may get bloated. So the symptoms to look for that we look for when somebody thinks about, well, you better have a colonoscopy, are basically changing your bowel habits. That's number one. Changing your weight, weight loss, decreased appetite, and abdominal pain. I will say those are the big ones. Bloating stool as well.
Okay, thank you very much. Dr. Tana, there's also a lot out there, kind of like with breast cancer, there's some hereditary components. Like with breast cancer, are there hereditary factors, or does colon cancer run in families?
I would say about 20% of the time, colon cancers will have kind of a family predisposition. Does that mean that there's an underlying genetic condition that led to it? No, but there's strong association with the familial colon cancers. So it is recommended that you know your family history well. I think it's very important that you share that with your physician, whether it's your primary care doctor or any other doctor. It's important that you know what first and second degree family members have been diagnosed with. There are tests that we do on tumor specimens that we can look at that help guide us. There are certain characteristics that we can look at on each person's tumor to help determine if they are at a higher risk for a hereditary condition. And that would lead us to do genetic testing to inform the patient and their family members. So I would just say it's very important that you know your history and share that with your doctor.
Okay, thank you very much. And Dr. Seth?
Let's see, we have here,
You mentioned, you already kind of stole the question a little bit, but we'll give it back to you. So why is a colonoscopy the gold standard?
Well, I guess intuitively, if you think about it, nothing can beat eyeing the colon. Colonoscopy gives you direct visualization of colon. Almost all the colon cancer, about 80 to 90% of the colon cancer arises from polyp. These polyps, to begin with, are very small, benign, just overgrowth of tissue. It takes about 10 years from a start of a polyp to turn into a full-blown cancer. So if you want to prevent colon cancer, you should have the ability to detect the smallest polyp. And that ability is only with a direct visualization, which is colonoscopy. So there is nothing that can beat colonoscopy at this time for early detection and prevention of colon cancer.
Don't sit down. This was a hot question the last group too, before we move back. Are the preps any better? Is it go light? In the hospital we say instead of go lightly, that's a common one. We say go lotsly. Right.
So that's the most common question that I get asked every day. The preps are better. Traditionally, it used to be go lightly, which used to be a gallon. Nowadays, we have low volume preps, which are half a gallon. On top of it, what we do is instead of taking the whole prep at the same time, we split it. So you take about quarter a gallon the late night or evening, the day before the procedure. The other quarter you take in the early morning. What I tell the patient, a couple of things they can do to make the prep more palatable. Make the prep cold, make it chilled. You can put some sweetener like something sugar-free or something like Crystal Light. Just don't put anything that is red, otherwise it will turn your colon red, look like blood. And drink the prep with a straw. If you drink the prep with a straw, it doesn't hit the front of your tongue where most of your taste buds are, and kind of kills helps you tolerate it a little better. So generally, between all this stuff, most of the patients are able to tolerate the prep very well. I had a funny story about it. We generally tell our patients to mix the prep with the clear liquids, and the patient came to me really drunk the next day, and I was like, what did you do? And he said, you said clear liquids. I mixed it in water.
Oh, no.
Just don't do that.
Yeah, that's probably not. So. It would probably make for a very interesting night, too. The trips to the restroom might have been very interesting. Thank you, sir. The last time I took a prep, I wish I'd had about the straw, because it tasted like I was drinking lemon pledge. It had like a furniture polish. If you were able to spray your tongue with furniture polish, that's the kind of taste. I bet a straw would have helped me quite a bit. So, so everybody's got their own little thing about what the prep tastes like. So yeah, that is a great hint. And cold, we know that in the hospital is better cold, and not with ice. You put it in your refrigerator cold, because if you dilute it with ice, that's just more of the stuff you gotta drink. So anyway, that's just a nurse tidbit there too. All right, Dr. Tana. So the chemotherapy, not necessarily targeted one, but does a patient have to be admitted to the hospital to receive chemotherapy for colon cancer typically?
Thankfully, these days, we've got excellent ways of administering chemotherapy. There was a time when patients were admitted to the hospital. They were given a continuous infusion of certain drugs because they have a short half-life, meaning that they're cleared out of your system very quickly. So we can't give some of the drugs at a high rate because the tumor won't see enough of that drug. So things have now been improved, and we have chemoports that can be placed, and maybe our surgeon can tell us a little bit about the chemoport, but we have devices whereby we can administer chemotherapy over a prolonged infusion at home. One of our most common regimens of chemotherapy given along with radiation is a continuous infusion for the full duration of radiation, meaning that 7 days a week we've got chemotherapy running in through your system. And that is possible to be done at home. Patients go home with a little cartridge, they have chemotherapy running in through their chemoport, and they tolerate it very well. Another common regimen that's given after surgery is 48 hours of chemotherapy. So a patient will come into the office, start their chemotherapy, and then 48 hours later come back to have it disconnected. So we do our best to make it as reasonable an experience as we can.
You know, things have changed a lot. When I first started in oncology 30 years ago, everyone came in the hospital for 7 full days, and they were the most bored patients in the world because they had to stay there with just an IV dripping every day for 7 days, all day long, and they were just like, they were our best patients actually, but they were the most bored patients because they really weren't sick. They were just in there because we had no other way to deliver, chemotherapy at the time. All right, so Dr. Asiana, if you do like what's the most common surgery for colon cancer? A colectomy, right? Is that one of the most common?
So a colectomy just means removing a portion of the large intestine that has the cancer. So we basically name the colectomies depending upon which side of your large intestine we take out. For example, if your cancer is on the right side, you get a right colectomy. If it's on the left side, you get a left colectomy. If we are talking about cancers lower down in the rectal area, those have different names that we get a little bit more technical about it. But overall, in general, a colectomy just means removing a segment of the large intestine.
So the recovery time for a surgery like that, is it real extensive, the recovery time?
So it all depends on several factors, and it's important to know that everybody's different. Everybody recuperates different after surgery. Everybody has a different pain level or pain tolerance, and so I would say that in average, with our newer approaches and our newer surgical techniques and all the new things we have available, the hospital stay ranges between 2 and 3 nights in the hospital, which that's my experience, and probably most of the younger generation surgeons coming with that kind of time frame. Of course, we're not rushing anybody out. We kind of evaluate you, kind of see how things are every day, and see if you're ready to go home or not. And then, if you need more days, we keep you. Really what we want to do is make sure that you go home safely and that you feel confident that, you're good and that you're not going to come back.
I'm asking another question. So is it a traditional, like, midline, or, going straight, do you open people up that way, or do you go through laparoscopic, through tubes, through small incisions? Is it do you do both ways, or depending on the patient, or?
That's another good question, and I think there's always a time and a place, and everybody gets evaluated in the office, and we kind of look at your risk factors for each of those procedures. But the open big incision, the big incision still is being used, still has a role in the treatment of colorectal cancer, but it's not, at least in our practice, is not the way that most of the colon cancers are removed nowadays. We tend to use very small, tiny incisions, either laparoscopically, which is 3 or 4 very tiny little incisions, or robotically, where we use the Da Vinci robot to help us as an instrument to help us through the operation. So basically we try to keep the incision small, and it has a lot of advantages, such as less pain after surgery, faster recovery, less wound complications, and we're really not compromising any of the cancer outcomes, and all the things that we look at, because it would not make sense to do all these nice little surgery with small incisions, but we're not getting what we really need to get, which is a good surgical outcome and your cancer outcome. So nowadays, to answer your question, recovery times, let's say average 3 nights in a hospital, feeling well, probably about a week later, some incision discomfort. Hopefully, at least my recommendations is you do whatever your body can handle after you get out of the hospital. If you want to go back to work, you can do it. Just don't lift anything too heavy because we don't want to hurt you. So it's whatever your body lets you do.
And hernia is probably not a good thing from surgery, right? All right, Dr. White, I mentioned when I opened up about colon cancer being most common over the age of 50. In your practice, are you seeing that kind of those kind of same ages? Are you seeing younger people in your practice?
I'd say most patients are over the age of 50, but we do see an occasional younger patient. I think I've seen patients even in their 30s that have had rectal cancer, and those tend to be the worst cases. I think mainly because younger people think that they can't get colon cancer and they ignore the symptoms.
So that's what I was kind of leading to. So if people are in the audience under the age of 50 and they start having symptoms, as Dr. Asiano mentioned, some of the symptoms of colon cancer, or they have a colon cancer history in their family, they shouldn't ignore these because, oh, I'm too young to get colon cancer, correct? They should be checked, because you have seen in our community, and I know we've taken care of the youngest. I think we took care of a 24-year-old with colon cancer. So that, and again, those are the oddities, or the numbers that you read about all the time, but it does happen. So none of us are invincible, right? I would say who's all current on their colonoscopy? Anybody want to raise their hand? All right, good. That's a very good percentage of the audience. Wouldn't you think, Dr. Seth? That's pretty good.
Nationally, 1 out of 3 are missing on screening.
So I think we're better than that. So you be very proud of yourself tonight. That is very good. All right, Dr. Asiano, I'm going to not give you one that's too difficult to or make you have to talk a lot more. You're answering wonderful questions. So tell me about are all, and Dr. Seth, I'll give you this other follow-up with polyps. Are all polyps bad?
So not all polyps are bad, and not all polyps are pre-cancers. There are different types of polyps. And for example, some of these polyps, as Dr. Seth mentioned, take some time, to have some cellular changes to become cancer. So the answer to the question is, not all polyps are bad, but it's important to find those polyps that have a slight chance to become cancer.
Okay. And Dr. Tanner, can we follow up with that with another question about polyps and let's see. I'm sorry, I missed my question here. Let me skip to Dr. Seth. I'm sorry, I had it down in my head. I apologize for that. Dr. Seth, we had a question from the last one about other conditions, and we're not talking about those family conditions that predispose you to colon cancer, and you can talk about that. That's what I'll ask you, Dr. Tanner, when we come back around, if you want to be thinking about those other hereditary syndromes. But we had questions about hemorrhoids, rectal bleeding, diverticulitis, Crohn's, those other common GI that you see a lot in your practice, I'm sure. Do those predispose you? Do those typical GI that a lot of us have those kind of things? do those predispose you or increase your risk for colon cancer?
So yes, some GI diseases, especially Crohn's disease, ulcerative colitis, also known as inflammatory bowel disease or IBD, they do substantially increase the risk of colon cancer over the years. So it depends upon how long the diagnosis has been made. So yes, some GI condition does. However, some others that you mentioned, hemorrhoids, diverticulosis, by itself do not increase the risk of colon cancer. However, when you mentioned rectal bleeding, for example, when you have a gastrointestinal symptom, just by looking at the symptom or talking to you, it's almost impossible to say if this is hemorrhoids or not. I've had people who would come to me and say, well, I have rectal bleeding and I think it is my hemorrhoids. Well, hemorrhoids are very common. Okay, about 50% of the people over the age of 50 will have hemorrhoids, probably even more than that. We just don't know about it. But not every hemorrhoid bleeds, and not every bleeding is from hemorrhoids. Right? That's what I tell the patient. So, by itself, hemorrhoid does not increase your risk. But if you have a rectal bleeding and you have not been evaluated by a gastroenterologist, then you need to.
So if someone has, and again, I know, I'll just name, right? All right, so we're going to talk a little bit about bloody stools and things here. So, right, so a bright red bleed tells you what, like, location in the colon that the blood might be coming from.
It can, to some degree. Generally, the higher up that the blood is coming from in the gastrointestinal tract. So let's say if the bleeding is happening in the stomach, it tends to be black. Okay, if it is happening in the small bowel, and if it is slow enough, it is still going to be dark and black. If it is in the colon, generally you see a maroon color, some clots. Left colon, more so clots. If it is rectum, anal canal, you see fresh blood. However, none of this is 100%. And which one of us wants to take that chance? I've had patients who come with fresh blood and say, I have hemorrhoids, and you go in and Dr. Aisanana was mentioning, they might be having a rectal cancer. A rectal cancer in the rectum is so close they can give bright red blood, versus a cancer or a tumor in the cecum, which is all the way on the right, can give you dark stools. Right? So yes, the color of these stools does give some indication, but it's not a foolproof measure of knowing.
Okay, thank you so much. That's very helpful because patients sometimes will say I have bleeding or it's my hemorrhoid. Well, again, you shouldn't be having a whole lot of bleeding from a hemorrhoid either, right? So that would be something you need treated. If it's not cancer, you shouldn't be losing blood that way either. We don't need to keep the blood we have, right? All right, Dr. Tan? So, all right, Dr. Tan, I am so sorry. When Dr. Asiana was talking about polyps, my mind sped ahead to I know I tested you with some genetic questions earlier, but there are a couple conditions, hereditary conditions that run in families. One of them is called FAP, and then there's another one, if you can maybe talk a little bit about Lynch syndrome.
Yeah, so there are some hereditary conditions that can not only lead to colorectal cancer, but other types of cancer. So when we take a good family history from the patient, when we look at the different characteristics of the tumor specimen, we do our best to identify what condition may be present. And the reason is we can impact the patient by improving screening. If it's a patient who has a hereditary condition, we might change our screening recommendations. It helps us decide when we need to look for other types of cancer. There are some conditions that are associated with breast and colon and ovarian cancer. So it's important to identify which other diseases should be investigated. And finally, to help family members. We, as patients, can help our family members if we know what they may be at risk for.
So if I'm in the audience, let's say I'm 53. I'm 53 and I wouldn't be told today I had FAP, a familial adenopolyposis. So that's a condition where there's hundreds and hundreds of polyps in your colon. It's not something that I would just find out when I'm 50. It would be something I know about. So if somebody's reading about it, because there people when they read about think they worry maybe I had FAP or maybe I would just, if you could just speak to that, it's something they would know for a long time, right?
So there are different types of hereditary conditions, some of which tend to present earlier in life. There are some that are associated with hundreds of polyps, and obviously those patients are going to be identified earlier in life. But there are some conditions that only carry a slightly increased risk of cancer, and those tend to be identified later in life. So I think it should always be a consideration when you're meeting with your doctor.
Alright, it's just, because sometimes it gets confusing, you know, you see some hereditary conditions, you might think, oh, do I have that? You would know if you had FAP, right? If you were like my age, you would already know that by now. Dr. Asiana, so if we've talked about colonoscopy being the gold standard, but say I have some medical conditions that maybe don't, you know, I'm not exactly a good candidate for the sedation maybe that, you know, that a colonoscopy requires. What are there other options for screening? I know colonoscopy is the gold standard. We all want everybody to have colonoscopy, but if for some reason you physically can't or it's not recommended because of another physical condition that you have, what are some other options?
Yeah, so that's another good question. Besides stool tests, you know, that Dr. Sendel already mentioned, looking for DNA cells and in your stool, it comes to my mind those patients that cannot, for whatever reason, they're, you know, cannot take a bowel prep, cannot, you know, they're not good candidates for a mild sedation for the colonoscopy. So then we try to look for alternatives, and you know, the two that are probably most common is you know, basically X-rays. One is the newest one is a tomography or a CT scan of your colon, which is a very specialized test. I'm not sure if we currently do it here, but it certainly is something that is common in bigger cities. And another one is another X-ray where we put some contrast in your rectum and then push it back to the right side of your colon, and then we take some X-rays on the fluoroscopy, which is like a video of your colon, and we're looking at growths, we're looking at masses and polyps, and some of these tests you'll be surprised are very good, but they can miss the smaller polyps, the flat polyps, areas of inflammation, and so those are options. The downside to those tests is that you still need to get a bowel prep, you still need to be clean. If there is a positive finding on these X-rays, you know, you fall back into, you know, we need to do a colonoscopy, we need to get a biopsy. So it's a good way to start if you have you know, if your risk factors are low and you cannot really be put under anesthesia or sedation. We can start with these X-rays. If they're fine, I mean, you're probably okay. But if there's something abnormal, you're gonna know that there's more to come.
All right, thank you very much. All right, Dr. Widener, you mentioned a little bit about the role of radiation, and so typically, you know, because maybe people have friends that are going through radiation, and maybe the rectum or another type of tumor in the abdomen. What are some of the side effects that a patient might experience from that kind of lower radiation in the pelvis, the rectal area, or in the colon?
The most common side effect is fatigue. Almost everybody going through radiation has some degree of fatigue. Diarrhea with rectal cancer is also very common. The chemotherapy agents that they often get during the radiation tend to cause diarrhea, and the radiation causes diarrhea. We have medication that can help with that. Skin reaction is usually not too severe. You usually get sort of a mild to moderate sunburn, and that's really it for the side effects that occur during the radiation. Nausea, vomiting is rare. Sometimes we can see some frequent urination because the bladder sits just in front of the rectum cell. We get some radiation, but any more serious or significant urinary problems is pretty rare.
You guys have a whole team of people that plan the radiation to avoid like bladders and things when you can, right? To help avoid those side effects, but it's kind of typically wherever they're shooting the beam is where you might have a side effect, right? Correct. And then I just want to say, anybody going through radiation, fatigue is the absolute most common side effect of any type of radiation, whether it's to your breast, to your colon, to your head, wherever. The fatigue is. It'd be interesting to know exactly why that is, but it really.
Yeah, I don't think we don't really know why it happens, but even some patients with tiny skin cancers that we're treating with radiation will get some tiredness, and I don't don't think we have a good handle on what the exact biologic reason for that is yet.
So as a friend or a family member of anybody going through radiation, something to be expected, you know, to have fatigue, and usually in a fair amount of especially when it's combined with the chemotherapy that Dr. Tanner would give. I'm going to get back to Dr. Seth. So let's talk about when you do a colonoscopy, and you know, we've talked about the prep, and you talk about how important it is, and some of the symptoms of why you might need it. But so when you do a colonoscopy, are there any inherent dangers for the patient, like a perforation or a puncture of the colon, or some other kind of complication typically?
Right. Just like any procedure, colonoscopy does have some inherent risk to it. The risk can include perforation, like you mentioned. Quite rare, depends upon the expertise of the person doing it. There is a risk of bleeding, especially when we remove a polyp. There are different ways we remove the polyp. If it's small, we can just take a biopsy forceps and take it off. If it's big enough, we put a snare. It's like a lasso that we put around and cut it off at the stem of it. We may or may not use a heat to cut it off. And depending upon how we remove the polyp, sometimes the bleeding can happen during the procedure, or even 3 to 4 weeks later on, especially when we use heat. It forms a little scab, and when the scab falls off 3 to 4 weeks later, that can be bleeding. There can be a rare risk of injuries to the organ surrounding the colon, especially if there has been a lot of intra-abdominal surgeries, which makes a colonoscopy very difficult. And sometimes when we are passing our scopes around the trunks, there can be some injury to spleen. Again, very rare. There is risk of sedation. We generally put a patient to sleep. We call it conscious or moderate sedation. It is not a general anesthesia, but depending upon the status of the heart and the lung of the patient, there can be some risk of sedation. So yes, there can be a long list of potential risks. If you put it like that, it sounds scary. But if you look at these statistics, all these risks are very rare. Most of these are less than 1 in 10,000 cases. And pretty much it really depends upon the expertise of the people who are doing it, and that's why you want it done by the physicians who are trained and who have an expertise in doing this. So that's
How many do you do a week?
In a week, I can do anywhere between 30 to 50 a week. Yeah. Generally, the recommended number would be that you would like to have it done by a physician, generally a gastroenterologist, who has at least 200 in their training and does more than 500 a year. That's the number that our societies who give us recommendations about what is an optimal number. That's the number they come up with. So it is a high volume procedure, and like everything in life, practice makes one perfect, right? So that's what it is. The more you do it, the better you get it, and the lesser is the complication rate.
So when you're looking through the colonoscopy and you see a polyp that looks, well, you're going to take every polyp out that you find.
Right. We don't
right. So they're not going to. He's not going to pass by and say, "Oh, that one doesn't look like cancer. I'm not going to take it." So when you go through, polyps are all coming out, right?
Right.
And so they go off and they're sent off. And what's the kind of a turnaround time for somebody to know if a polyp is cancerous?
So all the polyps that we see, we remove them. We do send them to a pathology lab, so a pathologist will take a look at them. Generally, a turnaround time, depending upon setting, can be somewhere between 2 to 5 days. Hospitals who have an in-house pathologist tends to have a rapid turnaround, so you can probably get the results in 2 days. Outpatient, sometimes it can take 3 to 5 days, depending upon where the pathologist is located and stuff like that. And very rarely we might have to do special stains, like Dr. Tanner was mentioning. And if that's the case, then it might take a little longer. But most of the time, within 3 to 5 days, we get the results. I would say about 95% of the time, if the polyp is cancerous or if something looks like a cancer, we can just tell it by the look of it. And almost always we are right. Very rarely we are surprised that something looked pre-malignant but turns out to be actually a cancer. So most of the time we can get you an idea at the end of the procedure, but the definite results we get it within 5 days.
Okay, that's good to know. Thank you so much. All right, I'm gonna ask Dr. Tanner we'll wrap up with, because it's 6:43. So we're all sitting in here, and besides the ones that have gotten their colonoscopies to make sure we're getting our good screenings, what are some of the modifiable things that we can do in our life? What can we control to help reduce our risk of colon cancer?
There have been a lot of studies trying to look to see what kind of risk factors have led to cancer or what can improve outcomes in patients who have been diagnosed with cancer. And a lot of things have been looked at. We've looked at things like dietary modifications, nutritional deficiencies like iron or vitamin D. And from what we can tell at this point is generally recommending a healthy lifestyle. We certainly recommend that patients are not smoking. I think reducing processed and red meats is helpful. There have been some studies looking at vitamin D deficiency and the role in cancer. At this point, we can't really make any recommendations on changing our screening, but it's really important that we try to lead a healthy lifestyle. And I think the other thing that's been implicated is obesity. So we recommend that our patients get exercise, they eat well, try to avoid red meats, processed foods.
Fiber, increase fiber in our diets to keep things moving, and low fat, those kind of things. All right, thank you so much. All right, so it is 6:45 on the dot, keeping things moving right along. I'm going to borrow the mic from Dr. Widener, and I'll